Hello and welcome back. Today we are going to discuss about two very important non-motor symptoms in Parkinson's disease and their management. In other words, what you can do as a patient or caregiver. The first one is the cognitive impairment, which is having problems with your thinking process, learning or making decisions, or many other things that we are going to discuss. Number two, psychosis, which means hallucinations or delusions. All these recommendations apply to patients with dementia with Lewy body as well. Let's start defining or explaining what do I mean with motor and non-motor symptoms. The motor symptoms are the ones that are easy to identify. Almost everybody can identify a resting tremor, like this lady. She's having a right leg resting tremor, and you see the tremor in the left hand as well. But also the stiffness is another non-motor symptoms, slow movements, masked face, the flex posture, decreased arm swing, usually asymmetric, the shuffling of the walking, and small handwriting. All of these are motor symptoms. Now let's talk about non-motor symptoms in Parkinson's disease. So the non-motor symptoms are the hidden phase of Parkinson's disease. Time-consuming, sometimes frustrating symptoms such as decreased sense of smell, low voice volume, painful leg cramps, sleep disturbance, depression, anxiety, constipation, drooling, sweating, hallucinations, cognitive issues, and many others. Remember, in Parkinson's disease, dopamine is not the only chemical affected. There are other chemicals in the brain that are affected and most likely decreased, such as serotonin and norepinephrine. And that's why patients with Parkinson's disease, they have multiple symptoms, motor and non-motor symptoms. Interestingly, more than 50% of the patient, then they are not going to tell you. When I say they are not going to tell you, they are not going to tell the provider about those symptoms during the office visit. And in average, they have 8 to 9 non-motor symptoms. And it doesn't matter for how long you have been having the disease. Now, very interestingly, as in this graphic, you can see here, this is the time 0 years in years when the motor symptoms start. And you can see that some of the non-motor symptoms can start even years before the motor symptoms, the tremors or the slow movements. You can see the constipation might start years before. That doesn't mean that every patient with constipation will develop Parkinson's disease, but there are some symptoms that are very highly associated with Parkinson's disease. For example, REM sleep behavior disorder, which is acting out during sleep. Those patients, the majority of those patients with REM sleep behavior disorder might develop Parkinson's disease or diseases similar to Parkinson's disease, like multiple system atrophy or dementia with Lewy body. And even you see the depression, also depression and anxiety can start years before the tremors and the slow movement. Now, look at this. The next one, you see here that this is the prevalence. This is the percent of patients that have the problem. So how frequent is this problem, right? So you see here that the slow movement, the stiffness, the pain, the tremors are very, very prevalent, very common. However, if you see here, the symptoms that actually affect quality of life in patients with Parkinson's disease. Now let's talk about what is dementia? Because there is a lot of confusion about dementia, if dementia is the same thing as Alzheimer. And it's different. Let me explain you what do I mean with dementia. Dementia means something that is acquired, right? So you were not born with this problem. You acquire cognitive issues. And in order to call it dementia, you need to have sufficient, the severity has to be enough to affect your daily activity and your independence. So you need to see a decline from prior level of function in order to call it dementia. Otherwise, you cannot call it dementia, and you might need just to call mild cognitive impairment. So you see that dementia is the umbrella term. After that, there are many causes of dementia, many causes of dementia. Alzheimer is the most common one. You see here that 70% of the patient with dementia, they have Alzheimer, but we have vascular dementia, which is the stroke-related type of dementia that you see. Let's define mild cognitive impairment. So when I say mild cognitive impairment, I mean cognitive decline that you test objectively. So there is a multiple standardized testing that we can perform in the clinic, such as mini mental status exam or the MOCA. All these tests these are objective testing to prove that you have cognitive impairment. But in mild cognitive impairment, the function is not affected. Patients still are able to function, to be independent. So the cognitive impairment is not severe enough to affect the daily activities, okay? That's the definition. Now, when we talk about subjective cognitive decline, it's a self-perceived decline in cognition, but normal testing. So when we perform in the clinic a mini mental status exam or a MOCA in the office, the test is pretty good. So you think, and usually those patients tell the provider, my memory is not good. My memory is very bad. I don't know what's going on with me. And this is very highly associated with depression, anxiety, and sleep disturbance the majority of the time, but not always. Now, let's talk about all the domains and areas in cognition. So this is a kind of complex slide, but bear with me. Because many people think that memory is the only one. When we say cognition, everybody think about memory. And memory is actually one of them, and the simple one, right? Very simple, the memory. Now, but there are many other domains like you see here: perceptual, social, executive function, language, and attention. So all of these domains and areas of the cognition work together. And some people develop better areas than others. And that's why we have some people very intelligent and some people not too intelligent. This is what it is. For example, a lawyer, if you want to go to law school, you need to have a good language skill. Okay, so this is a skills. And this is part of the intelligence, having a good language. So it's not the same thing as somebody able to speak 3 languages that a person speaking only one language is a huge difference. So this is one area. However, there are other areas. For example, the surgeons, they have a very nice, very well developed visual spatial function. They see things in that three-dimensional way. However, they might not have good social skill, okay, which is another domain. So how you interact with people, how you read body language, all these things are part of the social cognition. Now, this one, the executive function, is the most important one when we talk about Parkinson and Lewy body, because this is the one that is actually most affected. This is the predominant. And the executive function, think about if you are a CEO of the company and you need to execute a plan. So this is the skills that allow you to take decision, to have a good judgment, to tell you how you get from point A to point B, to execute a plan. And this is the part, the area of cognition that is affected in Parkinson from the beginning, actually. And this is why we ask patient and family, how is your memory? And they will tell you, my memory is good. There's no issue with that. That's true. Memory is okay. It's the executive function. So multiple task activity. This is the area of the cognition, the domain that is affected in patients with Lewy body or Parkinson's disease. Now, there also is attention is another one. Attention is another one. So there are some people, some patients that they have the capacity to pay attention and to be alert and attending and absorbing knowledge in better than other people. So this is another skill of cognition. And again, like I say, in Parkinson's disease and Lewy body dementia, the memory is relatively preserved. So that's why when you ask, they will tell you, my memory is good. And when you test them, the memory is good. Is the executive function, is the area of the cognition that is affected in Parkinson and Lewy body. Now, what is the difference between Parkinson's disease, dementia, and dementia with Lewy bodies? And this is a very common question that I get in the clinic multiple times. And very it's difficult to answer because we are not sure. Many experts think that this is a continuum of the same diseases, of the same disease. It's like the spectrum of Parkinson's disease. And I believe that we have multiple type of Parkinson's disease. The only thing that we call it Parkinson's disease because we don't know how to call it. But I believe that there's a multiple diseases. And like, again, we call it Parkinson's disease because we don't know how to call it. And the spectrum is huge. So you have a patient with only resting tremor and a little bit of slow movement, a little bit of stiffness, but you have the other side of the spectrum, which no tremors at all, significant cognitive issues, significant walking and balance issues, and this is the other area of the spectrum that we call dementia with Lewy body. So we don't know if this is, what is it? This is similar to ask which one is first, is the chicken or the egg? You see, the chicken and the egg. So we are not sure. Now, but just because a bunch of experts decided that let's divide this between 1 year, right? And we call that 1 year rule when we talk about dementia with Lewy body or Parkinson's disease dementia. So imagine that you have a patient with clinically established Parkinson's disease. So you have Parkinsonism, movement changes. So when I say Parkinsonism, I mean slow movements, resting tremor, and stiffness. So you have this patient and you diagnose this patient with Parkinson's disease. And then after 1 year, at least 1 year, because they decide that 1 year, the patient develop Parkinson's disease and dementia. You start having dementia, which means, remember I say, cognitive impairment with sufficient magnitude to affect your daily activity. This is dementia. Then you call that Parkinson's disease dementia, okay? So, but if you have dementia from the beginning and at the same time Parkinsonism, or dementia from the beginning and later you develop Parkinsonism, which is the movement changes, then you call that dementia with Lewy body. Okay, so it's a matter of which one is first. Let me repeat this again because this creates a lot of confusion. If you have the clinical diagnosis of Parkinson disease, so which means that you have Parkinsonism, and you develop dementia, significant cognitive impairment after 1 year, then we call that Parkinson disease dementia. If you started dementia first or at the same time that the Parkinsonism, then you call that dementia with Lewy body. Okay? Now let's talk about the most important part here, which is what to do with those cases, right? What to do. And this is the part that you care the most, the treatment. Now, the first thing is to treat. Let's go by steps. You need to look for things that you can fix. Okay. In neurology, we are limited in terms of what we can fix. We can treat, but we cannot fix usually. There are some exceptions to the rule. But there are some cases that patients start having cognitive issues, and you identify those cases and treat them, and patient gets significantly better, even in the setting of Parkinson's disease. For example, if you have a patient with Parkinson's disease, or even without Parkinson's disease, just having cognitive issues, but having sleeping issues, for example, sleep apnea, and you treat that, those patients might get better. You will see that your cognition will get better. That's why it's so important that if you suspect that you're having sleeping issues, see a sleep doctor, a board-certified sleep doctor. This is extremely important. If you have depression, treat your depression, okay? Treat your depression. Depression, you have treatment for that. I don't understand why people keep suffering and don't look for help. Look for help because we have medication, we have talking therapy. There are many things to treat depression. And one of the most important things that this is the first thing that I see when I see a patient in the clinic, the first thing that I will ask you is medications. So, and I don't care if the nurse or MA check the medication first, or you think that I'm supposed to know your medication. No, I will ask you again, because that's the most important part, making sure that I know which medication you are taking. For example, because there are many cases that doctors or providers actually are causing the memory issues in patient or cognitive issues in patient. Let me give you an example. There are medications such as bladder pills that we use that in some susceptible patients might cause cognitive issues, memory issues, such as, check this, oxybutynin, this one, I don't know how to pronounce this one, and this one too. So these three medications, and the one that I see a lot is oxybutynin. So I see a lot of patients in the clinic that they are diagnosed with dementia, and look at what I'm doing. And actually they are taking medications for dementia that approved by FDA for Parkinson's disease dementia or for Alzheimer, and they are taking oxybutynin. That doesn't make sense, because oxybutynin will cause the opposite effect that the medication that we use to treat your questionable dementia. Okay? So the first thing that you have to do is stopping this medication, and you actually can stop this medication cold turkey. Okay? Stop this medication. The worst thing that can happen to you when you stop this medication is like, because this medication is to treat overactive bladder. So which means that if you don't take a medication to treat your overactive bladder, you will be waking up a lot, right, at night, or you have to pee a lot frequently. There are other medications that you can use without going to the brain, because these medications, they are, we call anticholinergic medication. Specifically, these three medications penetrate the brain. The brain has a barrier. We call that the blood-brain barrier. So those medications penetrate the brain. and then can make you confused, but can make you, well, as I say, cuckoo. Okay, so that's the first medications that you need to stop. The second group of medication is actually medication that we use for Parkinson. This medication, very difficult to pronounce, 3-hexyphenadiol. I can count with my hands, and I see patients with Parkinson all day long, how many patients I have on this medication. Why? Because we don't use this medication at all currently, okay? I have one guy taking this medication, and he's 40 something, a lot of tremors, and I did not start the medication, somebody else. So, and I continue, and I wanted to stop this medication, and we tried to decrease, but we tried to decrease, and the tremor got worse, so he's back on the medication. And because he's not having any cognitive issues at all, that I think, so we kept him with this medication. He's not having any side effects, so that's why. Other medication that might cause cognitive issues in patients with Parkinson, you have to be careful, is amantadine. So amantadine, it doesn't have the anticholinergic effect like this one here, but the anticholinergic effect of amantadine is weak, but still you might have issues, okay? So especially in susceptible patients. So this is a medication that unfortunately is the only one that we have to treat dyskinesia, which is the dancing-like type of movements. But especially in the setting of renal failure, it gets accumulated because this medication get accumulated when you have renal failure. So when you get dehydrated for whatever reason, and you are taking amantadine, and you suddenly develop problem with your speech, and you are jerking, and you are confused, this is the medication that you need to taper down or decrease, okay? It's very common, the amantadine. Now, the other ones that we are moving away of using this medication currently in 2024 is the dopamine agonist, because there are many side effects. Still, they have a role in the treatment of Parkinson's disease. For example, let me give you an example. A patient with a female patient, younger patient with depression, with sleeping issues. So those patients probably I might start this medication. So still there is a role, but if you're having significant cognitive impairment, it's better to stay away of this type of medication, the dopamine agonist, okay? Another one, antidepressants. So there's some antidepressant with significant anticholinergic effect. Again, I'm talking about anticholinergic effect. Amitriptyline and dozapine, there is a bunch of data about dozapine in patients with Parkinson, but these are all data. So I rarely see patients taking dozapine because these dozapine and amitriptyline, these two, specifically these two, they are what we call tricyclic antidepressant. They actually penetrate the brain very well, but they have a potent, very strong anticholinergic effect that can make you very confused and you cuckoo, okay? Now, this is another medication that very commonly used, and I will stay away of this medication if you are over 65 or you're having cognitive issues, because even though that the anticholinergic effect is mild, still it might affect you. You are susceptible. Okay, paroxetine. That's this one, paroxetine. Stay away. Remember, those medications you cannot stop cold turkey, or otherwise you will have withdrawal symptoms. Okay, you need to ask for guidelines how you are going to taper down those medication or to switch to something else. Okay, these are antidepressants. Let me see if I have more here. Painkillers, yes. So painkillers is another way to make your cognition worse. So I don't know. I don't prescribe painkillers almost almost any patient. I have a few patients taking oxycodone long-acting if the insurance cover, but it's because I'm treating RLS. Those patients, sometimes they respond very well to narcotics, but only if you have RLS. Otherwise, I don't use narcotics at all. But those patients might affect your cognition, okay? So try to stay away of this type of medication if you can. Now, sleeping pill is another one. So sleeping pill like lorazepam, clonazepam, I prescribe clonazepam because it's the most effective treatment for REM, sleep behavior disorder. So if I have a patient who is punching, kicking, moving a lot, screaming, falling from the bed, and having issues with that, I have patients that hit the wall. So if safety is an issue, this is a medication to use. But you have to monitor cognition because it might affect your cognition. Alprazolam or Xanax, I don't have patients on alprazolam or Xanax. I don't like it. Yeah, and the patient that I have are patients that they were prescribed this medication before, and I got the patient, so I continue because patients are relatively doing well, and the problem is that it's short acting. You have a rebound effect. So I typically don't use alprazolam at all, except if the patient, if you are on this medication and I don't want to mess with you because you are relatively stable, right? Benadryl is another one, very common, very common. Benadryl, remember, Benadryl make your RLS worse. So this is a very important detail of Benadryl. So if you think, let me take a Benadryl to see if I sleep better. But you realize that when you take Benadryl, you cannot sleep. You feel tired, but you cannot sleep because your legs are bothering you. Because there are some patients that are susceptible when they take Benadryl, the RLS, restless leg syndrome, and I have a video about that. The symptoms get worse. And not only that, if you are susceptible to this type of medication with anticholinergic effect, like an anticholinergic effect, also might make you confused. So be careful with the Benadryl, okay? And anything PM, like Tylenol PM, this type of medication also might affect cognition, Ambien, Lunesta, all these things. Let me see if I have more. Muscle relaxant. So cyclobenzaprine is another one, very common medication used to relax your muscle when you have pain. Also, this medication penetrate the brain, the blood-brain barrier, and it has some anticholinergic effect. Okay. Now, these are causes of dementia-like symptoms. So things like mine looks like a patient with dementia, but you actually can treat those patients. It's dementia-like symptoms. So for example, if you are depressed, like I said before, you treat the patient and the patient cognition improve, right? You might have focal seizure. Focal seizure, my patient might act weird, might act not acting themselves. Patients are not acting right. And maybe the patient is having a seizure, a focal seizure. Vitamin deficiency, specifically vitamin B12, very common to have vitamin B12 nowadays, okay? And for some reason, maybe due to absorption, I see a lot of patients with Parkinson disease having vitamin B12 deficiency. And you can treat that, very easy to treat. Even orally, you absorb high doses of vitamin B12 orally. At least 1,000. We typically prescribe 1,000 micrograms on daily in patients with deficiency. You have folic acid and thiamine too. Now, metabolic process. So there are many metabolic processes, including thyroid. Thyroid is the hormone, right? Thyroid, this is the hormone thyroid. So when you have a hypothyroidism, you might have issues with your cognition, low sodium, calcium, and many other electrolytes. And there are some patients that they accumulate CO2. And those patients also might have altered mental status, confusion, and all these things. Alcohol. If you drink alcohol for heavy alcohol, because if you drink a wine, that's not a big deal. Some people actually recommend that for your heart and your brain, but I have a question about it. But if you drink a lot for a long period of time, that will affect your cognition. Again, also a simple infection, like for example, if you are okay, you are basically acting right, normal, and suddenly you are kind of confused, or you identify that your dad, your mom who has Parkinson, suddenly today she started having some confusion. She might be having an infection, might be a UTI. So you need to talk with your primary care provider to see if she or he having an infection. Okay. Now, liver or kidney issues. So, and we talk about this in the metabolic process, because if the kidney is affected, you might have issues eliminating medications that are metabolized, or actually not metabolized, eliminated by the kidneys. The same apply with the liver. So there are some medications that are metabolized in the liver and it get accumulated. And then you have toxic effect, right? And again, the big one is a sleep disturbance, especially obstructive sleep apnea. That's a big one. Now, what type of pills we have for dementia? And I'm talking about Parkinson's disease, dementia, and Lewy body, okay? The first thing I have to tell you is that there is no cure, okay? The only thing that we have here is a medication that might help. It's a modest effect. In other words, do not expect a drastic positive changes, because you are not going to see that. You might see, if you test the patient, you might see 2 or 3 points improvement. For example, you have a patient who can score 19 over 30 in a mini mental status exam, and then you give these pills and you test again and might improve 3 points. Something like that. And actually this is not too accurate, because fluctuate many times. So, and when we talk about medication, the only medication that really shows some benefits is this one here. I'm talking about in the setting of Parkinson's disease dementia, right? Rivastigmine, which is excellent patch or the capsule. All of these medications that you see here, rivastigmine, donepezil, and galantamine, we call that cholinesterase inhibitors, right? So, and like I say, modest benefits in terms of cognition. So, but this is the only one approved by FDA to treat Parkinson's disease dementia. But that doesn't mean that donepezil might work too. And actually, I use donepezil as a first choice because it's cheaper, and I don't have issues with insurance with this one. But if you have a good insurance, medical insurance, ask your doctor to prescribe this one first. But if not, just go to just try that donepezil. That's fine too. Okay, donepezil 10 milligrams. You start with half of the dose. In the pharmacist will tell you to take it at night. Donepezil, don't take it at night. Take it at lunch or in the morning. Why? Because these medication, all of these medications, the cholinesterase inhibitors, it might cause, if you take it too late, it might cause exacerbation of your vivid dreams. Vivid dreams, okay? So very important that you don't take this medication too late. Sometimes you will have this issue, it doesn't matter. Taken in the morning, because this is a medication that are long-acting medication, right? Except the rivastigmine, which is you have to take it twice daily, unless it's a patch. So the pharmacist might tell you that doesn't make sense to take it in the morning because it's a long-acting. It might be right. So, but I still recommend it, and many of my colleagues, behavioral neurologists, recommend to take excellent patch. Excellent the capsules, the pill, and the donepezil early in the morning. And in the case of rivastigmine, which is the excellent, dinner. So not too late, in other words, not too late. Galantamine is the other choice. Now, remember the side effect of this medication, the most common one is this one here, nausea. Okay, you might have diarrhea, and it might cause a worsening of the tremors, that you might see some more action tremors in patients, but typically patients tolerate the medication pretty well. I always tell patients that you will have probably 20% probability of having these symptoms. It might be a little bit more than that, but in my experience, I think I'm right in terms of saying that 20% of the patient might have these issues, and it usually goes away by itself. But there are some patients that cannot tolerate the pill, and they need the patch, and so the patch is less likely to cause these GI side effects. Now, another medication that the data is mixed, and I typically don't use it, but sometimes I do. Especially, I just tell the patients, the family, actually, in this case, the family, because the data is so mixed, and there are a bunch of paper that the benefits are basically nothing in patient with Lewy body or Parkinson disease dementia, the use of Namenda. Okay, so sometimes I use it, sometimes I not. But the most important one is to use the first one that I mentioned here, this one, the cholinesterase inhibitors. Namenda you can consider. The side effects are actually people tolerate memantadine better than cholinesterase inhibitors. I rarely have a patient that they cannot tolerate Namenda. And when they cannot tolerate it because for some reason that I don't understand, it might worsen hallucinations in some patients. Okay, and then the family will tell you, I started this medication and in 1 week the hallucinations got worse. So, and then I tell them to stop the medication. Okay, stop the medication. Now, let's talk a little bit about OTC supplements, so over-the-counter supplements. So, there is no significant evidence. There's no significant evidence, okay, about using supplements to reduce the risk of having cognitive decline, okay? And I'm talking about all of this that you see here, omega-3 fatty acid, ginkgo biloba, folic acid, or vitamin B, vitamin C, vitamin D, or calcium vitamins, all these things that we all take. And actually, I take a multivitamin when I remember. I take Centrum. There is no evidence. We take it just in case, but at least there is no side effects. There's rarely you will have a side effect. Unless you have a accumulation of vitamin B. There's some vitamin B that get accumulated. For example, vitamin B6, it get accumulated, you might end up having neuropathy. But the doses in a multivitamin of vitamin B6 are very low, so it's extremely unlikely that you have a toxicity. Okay, so the bottom line is basically that it's insufficient data to recommend supplements to treat cognitive issues unless you check vitamin B12 or folic acid and it's low. So in those cases, you treat. Now, let's talk about psychosis in the setting of Parkinson's disease. So psychosis, it might happen in 25 to 40%. So it's pretty common. And unfortunately, psychosis is highly associated with disease duration. So you don't see psychosis during the beginning. This is very rare that you see psychosis, and you see psychosis from the beginning. You probably are dealing with another type of diagnosis. Okay, you are not dealing with Parkinson's disease. But in medicine, everything is possible, right? So, when you have psychosis, this is highly associated with cognitive impairment, okay? And especially also with excessive daytime sleepiness. So those patients with psychosis, they tend to have cognitive impairment. When you test them objectively, you will see a low score, so below the average. You will see that. You will see also many times excessive daytime sleepiness and RVD. RVD means REM, sleep behavior disorder, acting out during sleep, and many times depression. Remember, if you treat depression, cognition usually get better, okay? And unfortunately, when you have psychosis, this is highly associated with nursing home placement. So by far, this is one of the risk factors if you're having psychosis that you will end up in a nursing home, okay? Because it's just very, very difficult to deal with the situation. A lot of caregiver stress. So if there are few things in Parkinson that affect the caregiver life, it's not actually the motor, is number one, the psychosis of the patient and the apathy of the patient, which is another thing that I'm not going to talk now, but apathy is another non-motor symptom that affect the caregivers or the spouse or the family, okay? Now, this is the type of psychosis that you see in people with Parkinson, the such hallucinations. So these are basically that you see things in the corner of your visual field, and you look and there's nothing there. So sometimes it's like passing, something is passing, and then you look and there's nothing there. Then illusions. So illusions are misinterpretation. So you see there is a tree and you think is a person. Okay, so it's a misperception of something that you are seeing. And hallucination, which is the most common one, that typically is well formed. They see animals, they see a kid, they see something very clear, people, animals, are the most common. And so basically, seeing things that are not there. Seeing things that are not there. This is the definition of hallucinations. And delusions also are not actually common. Delusions are false belief. False belief not shared by others. So you see that in patients with Parkinson as well, but they are very, very rare. Now, how do you manage psychosis in the patient with Parkinson's disease? If acute, so acute, sudden onset, you need to rule out infections, because infections, for example, pneumonia, so infections of the lung, or a UTI might cause acutely psychosis in susceptible patients, such as patients with Parkinson's disease, because the brain cannot compensate anymore. The brain is fighting against your body, your brain is fighting against infection, so it's not able to compensate. So you will see more things. So you will see more symptoms, including non-motor symptoms like a psychosis. Electrolyte disturbance is another one, metabolic process, right? So if the workup, when you have a patient, acute onset of hallucinations out of the blue, everything was okay, and now he's seeing things, you make sure that the patient is not having infection process and everything come back negative, and the hallucinations are not bothering them. Sometimes you don't need to do absolutely nothing, okay? So you don't need to treat every single symptom in patient with Parkinson's disease. Only if the symptom is affecting function or safety. That's another one, or safety. So the first thing that you have to do, which is the easy one is just to, again, review the medication, right? So you tell your primary care doctor, your Parkinson doctor, or your neurologist, this is my medication list. What medication I'm taking here that might exacerbate my hallucinations? Because I don't like these hallucinations. There are some patients that like hallucinations. I have a few. But the majority of them, no. It can be a very, very stress situation, right? So Sometimes we need actually to decrease the medication that we use to treat Parkinson, okay? And sometimes even to stop, because medication that we use to treat Parkinson, because increased dopamine, might exacerbate hallucinations in patients with Parkinson's disease. So basically, you decrease or discontinue some of the medications, Parkinson medication, except the levodopa. You need to be on levodopa forever. If you have Parkinson's disease, you need to be on levodopa forever. Okay? Uh, I have I have some patients that they have the diagnosis, the clinical diagnosis of Parkinson's disease, but the symptoms are very mild. They are not on levodopa, but they take, because the symptoms are mild, they can actually compensate with another type of medications and exercises. So exercises is key. Okay, but again, this is another topic. Now you need to stop. This is the order that you need to stop the Parkinson medications. Okay, you start with this one, which almost anybody use this medication in 2024, but there are some patients, right? So that's the first one to stop because it has a strong cholinergic, anticholinergic effect. This one, Artine or 3-hexaphenadiol, 3-hexaphenadiol. Amantadine is another one, which the anticholinergic effect is weak, but still there. And especially if you have a renal failure, it gets accumulated and it might cause significant cognitive issues in patients. Risangeline and salangeline, okay? That's another two that we need to taper down, right? When you have psychosis, when you have a patient with psychosis. So, and remember, and those patients when they are on psychosis, because psychosis is very common at late stage. So at that stage, you need to simplify things. So you need to start tapering down medication and just concentrate in levodopa only, okay? And manipulate the levodopa and start tapering down medications. And sometimes doctors, providers, we try to manipulate, adding this, adding the other one, and what we are causing is a mess. It's just a bunch of medication, polypharmacy, and patients are doing worse because we try to help adding medications and we are making things worse. Okay, so it's better to eliminate medication and play with the safest one, especially at late stage of Parkinson's disease. And if you ask me which medication is the safest one, with less side effect is levodopa, okay? Now, if you have cognitive impairment and you have psychosis, consider the use of this medication, okay? Excellent. Or rivastigmine. Rivastigmine is too expensive, then use Aricept, donepezil, okay? Now, this is very interesting because this is the recommendation by the Movement Disorder Society. Recommendation. This is a paper published in 2019, I believe, and they recommend this medication, the Nuplazid, okay, for psychosis. So I'm talking about medication to treat psychosis in the setting of Parkinson's disease. So medication to treat psychosis in Parkinson's disease. So because remember, the first step is to try to eliminate medication, right? Eliminate medication. You don't start medication right away. You eliminate medication. And then if you ask me, is there any pill to treat this? Because we stop this, we stop that, and still patient is having hallucination. What pill can I use? Well, I typically use, because it's easy to get, because the insurance is not going to give you a hard time, because it's cheap, is Seroquel or quetiapine, okay? Seroquel, quetiapine. But the evidence is very, very vague. So there are some patients that respond. I don't know if the medication is helping because causing them to be sleepy, and that's why they are decreasing the hallucinations. I'm not sure about that, but there's some help. For sure, it's gonna make you sleepy. And maybe if you are sleepy, you are not going to be complaining of hallucinations. So this is one way to see this. But that's the only thing that we had before until I think nuclacid or pimavanserin was approved, I believe, 2016 or 17. I don't remember exactly, but before that, we didn't have anything. We just have quetiapine and clozapine. And clozapine is pretty effective, actually. I have a few patients taking clozapine, but the problem is that you need to monitor a CBC very frequently, especially during the beginning, during the first 6 months. It's just almost every week. So it's very tough to get this pill and to have the patient getting a blood test every week to monitor the white blood cell count, because approximately 1% they have a severe side effect. The white blood cell count decreased significantly, and you will be predisposed to have a severe infection that might kill you. So, and that's why we don't prescribe clozapine a lot, like quetiapine, which is pretty safe. Now, if you can, the first choice should be this one, okay? Because the data is there and you see the efficacy, so it's very effective. And remember, take time to work. So if you take this medication, don't give up the first month, because sometimes it might take 2 months to work, okay? Take forever to work, but tend to be effective in my experience. This medication is pretty good. This is nuclacid. So that's the only thing I have today. If you like this video, don't forget to subscribe to my channel, and see you soon.